Moving on to population. Population is also important because this actually affects both your internal validity and your external validity. It affects your internal validity because if you don't have a specific enough population, then it could be that you're treating patients who don't have the disease state, or it may be that you're including way too many patients that may be outliers or safety concerns. But if your inclusion-exclusion criteria is too limiting, then that might affect your external validity, because if you only look at a very, very certain specific group of patients, you might not be able to see that be extrapolated to other populations. Now, whenever we look at the populations, the first thing we like to look at is like what kind of population we use. So you have intent to treat, modified intent to treat, and per protocol. These are the major types of populations you'll see. So ITT, or intent to treat, that means that anybody who got randomized gets put into the study. Versus a modified intent to treat, that means that patients are randomized plus they have to do something else. So things like a lot of trials that look at safety will make patients have to be randomized and at least receive one dose of the drug. And then your final group is your per protocol population. These are patients that complete the entire trial and are adherent to the protocol. So this is kind of like your perfect population. Sometimes you even call it the per perfect population. Now, population is important for a couple different reasons. One thing is that, take a moment and think about this. Which one of these, the intent to treat, modified intent to treat, or the per protocol population, is the most like what happens whenever I'm in clinic and I just give a patient a drug and tell them to start taking it? Many of you guys should be saying, well, that's the intent to treat population, and that is so true. That is so true. Like, the intent to treat population is the most like what's happening in real life. And that real-like efficacy or effectiveness is known as effectiveness. Versus, you have the per protocol population, or the PP population. This is the patient populations that you will absolutely know what the drug is doing. And so it does a good job of measuring efficacy, or in a perfect scenario, does this drug work? So when you're looking at your populations, you're going to have to start thinking to yourself, is this going to reflect real life, or it's an intent to treat, or per protocol, or showing like efficacy? A lot of studies may actually run analysis on both. Now moving on to inclusion-exclusion criteria. Again, these both affect internal and external validity. And inclusion and exclusion criteria have very specific uses. 1. Inclusion criteria, the major goal is to make sure that we enroll patients that have the disease. So what you're looking for there is the diagnostic criteria for the disease. So if you have a patient with COPD, you're saying that I want to include patients that have moderate to severe COPD, and they define what moderate to severe COPD is. Versus exclusion criteria, their major goal there is to make sure that we eliminate any outliers or patients that may either over-respond or under-respond to the drug therapy, or also wanting to exclude anybody who's a safety concern. So there are many, many drugs that are therapy category X, or I guess now we don't even say X, but are pregnancy category X. In any of those trials, in drugs like ACE inhibitors, you want to avoid putting pregnant patients in there. That is a safety outcome. Now, another example is when patients can be an outlier. There are a lot of drugs that work similarly. Like, once you guys get into diabetes, you'll get this one, but GLP-1s and DDP-4s. They both act very similarly, and so being on both therapies has been shown to not be much more effective than being on either therapy alone. Those patients would be outliers. So you want to make sure that we're trying to remove anybody who might have a safety risk and anybody who might over or under respond to medications. And again, the major goal here is to control for internal and external validity. If this is too specific, you're risking your external validity, but will probably have better internal validity. Versus, if this is not too specific and everybody's included, that might improve your external validity, but decrease your internal validity. Now, one thing you want to remember as well is that many of these trials may have what's called a run-in phase. Now, the run-in phase can either be a good thing or a problematic thing. With a run-in phase, that means that you're making patients take a dose of the drug or do something for a period of time before they come in. Sometimes they use run-in phases to measure like the baseline characteristics of patients. Other times, they'll actually use this to eliminate patients that might have bad safety outcomes. What you want to consider here is if there is a run-in phase, make sure that it's not excluding patients that may be having these safety outcomes or maybe outliers to make the drug look more efficacious than it actually is. So I always tell students to be aware of this. The next thing I want to talk to you guys about is withdrawals and displacement. We do want to make sure that every study is clear in the frequency and the duration of patient follow-up, along with that they account for every person at the end of the study. This is important because you don't want to leave the study for many reasons, including death, treatment complications, treatment ineffectiveness, and complications. So you want to make sure that you know exactly where all those patients end up. There is what's called the 5 and 20 rule of thumb. That means that if there is a 5% dropout rate, it's probability that there's the least amount of bias. If it's greater than 20%, so if your dropout rate's greater than 20%, there's probably serious threats to the validity, meaning that withdrawal rate means that not a lot of patients actually took this drug, so there must be something else going on there. Again, keep these in mind as you're looking through trials. When we're looking at populations, the questions we want to ask. So, population use is first. Again, we're going to use this population use to decide what kind of trial we want to use or what this trial is trying to measure. Intent to treat, we're looking at effectiveness. Meaning, if I give this drug to my patient, depending on, some might be adherent, some might not be adherent, but this is real world. First is per protocol population, where we're looking at efficacy. This will be more dependent on the type of trial you're using or what you're trying to actually measure. You also want to make sure that your inclusion criteria identify the appropriate patient population in your exclusion criteria, eliminate anybody who is a safety risk or who might be an outlier. You're going to have to spend a lot of time trying to weigh the internal and external validity for that section. And then the next thing is that you want to make sure that all the patients were accounted for at the end of the study, and if not, if they're missing patients, were they addressed for. You want to avoid having patients you want to note if there is more than a 20% withdrawal rate in a study. These are found in multiple different sections. So for the population used, like the ITT versus PP, that's actually going to be found in statistical analysis. Inclusion and exclusion criteria are usually located in the methods section with participants. For the withdrawal rates, that's usually in the displacement chart. So that's that flow diagram that will say we started with this many patients, this many excluded, this many excluded.